welcome everybody. My name is Trish. I am a physical therapist in Rhode Island, and I do treat pretty much every one of these conditions is the majority of my caseload in our clinic. So I was asked to speak on physical therapy as it relates to all of these conditions and their comorbidities, but also a very specific twist. There's going to be a lot of info that we're going to skim over because we just don't have the time to go into. But the specific twist is, a lot of you in this room, often I know, we are the last people you want to see because you've had such bad experiences with PT in the past. So I was asked to speak about why I'm not a horrible person and why physical therapy really will help you and why it shouldn't be frowned upon. So, disclosure, I am on the board of directors of the Dysautonomia Support Network, running this organization, but I have nothing financial to disclose. There are pictures of patients in the slide, but there are waivers for that information about their story and about their photos, and all of the discussions in this are for just general discussion only. I will not answer any medical or directed personal questions. Same thing. Okay. So the objectives for this, basically, I want to go over what do PTs treat? What is our job? What are we actually treating? The difference between what we call structural and functional therapy, and then this is where this is going to be really important, is how to choose a PT, and then more importantly, when should you lose your PT? And then kind of a pet peeve of ours, of mine especially, is we've gone through treating a lot of these patients, being very cautious with your wording, and so how to kind of decode some of the PT terms and clean up some of the things that we use when we discuss things with our doctors. So we're all speaking the same language and we're getting good results and outcomes with everything. And that EDS is more than just a joint problem, which I think you're all very well aware of. So we're going to be able to skim over a lot of that. And then just the interconnectedness of everything. It's my official term there. So my very unique perspective of, like I said, why we want to do this. But the first, I always like to thank kind of who brought all of this to light for me. So I am speaking specifically because I am not your standard PT. So I was trained with a very specific osteopathic manual therapy background, and I always start this lecture by thanking my personal mentor and my first PT and professor in this, and I'm actually very blessed that he happens to live in Maryland and did come today. So Mr. J.R. Buckland, you're amazing. And then something popped up on my screen. And then the physicians that are speaking here, I work very closely with, and dealing with them directly also is how we get all of our information, the fact that we collaborate on everybody, and then most importantly, the patient. So we learn everything that we know about how to treat patients with EDS by having patients with EDS. That's about it. There's no other way to learn this. So I don't treat EDS. I treat patients. I don't treat Chiari. I treat patients who have Chiari. I am very careful. I don't treat any of these disorders. That's not my job. I'm not a physician. I don't treat you at a cellular level. That's not what we do. And so I treat patients. I don't care what diagnosis you have when you come to me. Your body is your body. Your anatomy is anatomy. And your biomechanics are still going to function the same. You are very special considerations, but are you really any different than every other patient population? Not if you're looking at patients as a whole person. No, you're not. You're just people, and that's how your therapist should be treating you. So that's something we want to look into, is you shouldn't be treated differently because you have a condition. You just need extra precautions. So why physical therapy? So like I said, if I have one goal of this entire presentation, the only thing I want you to walk away from today is that physical therapy can do a lot for this patient population. So if you walk away and remember nothing but this slide, I'll be happy. PT is not just exercise. We are not personal trainers. We're not just exercise people. And physical therapy for especially connective tissue disorders, it goes far beyond just treating the muscles and the joints. And we treat connective tissue. That is literally our job description. We don't treat a specific joint area. We treat connective tissue. Joints are made of connective tissue, but so is everything else in your body. So we treat the whole body, period. No discussion. So if that's not happening for you, that's when we're going to look into later, is your PT really helping you? So PTs treat what we call somatic or body dysfunctions. We treat the altered or impaired function related to the components of the somatic system. Very fancy wording for what I just said. PTs treat the whole body. So we treat connective tissue as it relates to every system and function and joint and area of the body, with a special particular focus on the myofascial and skeletal systems, which is what people pretty much all ever give us credit for, but also their related vascular, lymphatic, and neural elements. So these comorbidities attack all of these areas, so you should be addressing all of these areas with your patients, or your providers should be addressing everything. You cannot just be the shoulder guy. You can't go to a PT who's the shoulder PT. If they are, then they're not the right fit for you, and we'll talk about that too. So again, we're going to go through a lot of this pretty quickly because it's going to be talked about all weekend, but connective tissue disorders, connective tissues are made from the building blocks of collagen, and collagen is the glue that holds your body together. When there's a defective issue at the building block of your system, and there's a defect in that tissue, it leads to a systemic weakness and instability, not specifically just a joint weakness or a joint instability. If collagen is present in everything, and there's weak or loose or defective collagen, everything is weak, not just one structure. It may be more symptomatic in one structure for one person versus the next, but the whole body is weak, and so the whole body needs to be treated. And yes, it's not just stress that you're losing your stripes and things are starting to fall apart. The glue lets go, and the glue just kind of is what's holding you together, so you don't have enough glue, and that's the problem. We're not going to go through all the symptoms, but this is the list of symptoms you're going to see from everybody. The only thing I want you to take away from this is that these symptoms are not specific to one area of your body. These symptoms are symptoms of Ehlers-Danlos syndrome. They're also overlap to every other comorbidity that's here in this room. This is the same list of symptoms, which is what makes it very difficult to treat patients with this, because you don't know what's coming from what. And the other problem is that you can't just, like I said, you can't just treat the knee. If they're having knee pain and then it's affecting X, Y, and Z, it's because they're all connected. So these are the symptoms for all of the conditions, and they should all be addressed or at least be mindful. It's not, like I said, it's not my job to treat your medical condition, but if your medical condition is contributing to your functional status in my clinic, I need to be aware of all of those things as well. So this is my analogy that I give everybody. If you've seen it before, I'm sorry. So this is what a typical house would look like. So if you see a patient coming in and they're your standard typical patient, this is what they look like. If you have a patient with EDS, or you have your house with EDS, this is what they look like. I don't know about you, but to me, they look exactly the same. I'll give you a hint. They're the exact same picture. I picked the same one. So they are exactly the same from the outside. There is no difference looking at them from the outside. But when you look at them closer, the standard house is built with really strong 2x4s, and there's a lot of them. There's no deficits, there's no holes. But if you look closer to a patient with a connective tissue disorder, there's less 2x4s in their building, and the 2x4s that they have are riddled with termite damage. So they're not as strong as the house built with standard tissue. So over time, if you don't take care of it properly, or in general, just gravity, a lot of the patients walk into my clinic and they start to look or feel like this, because now your house has started to fall down because you didn't have the proper support structure at a structural level. So the difference of what I would say is how we treat is the difference between what we call structural therapy and functional therapy. So structural rehab is treating from more of the osteopathic standpoint of looking for the root cause of what is causing the dysfunction and then treating that, not just chasing a bunch of symptoms. So you may come into my clinic and tell me that your shoulder hurts, and I may say, that's very nice, and I evaluate you, and then we don't treat your shoulder, we treat your neck. Well, you might get mad, but that's because your shoulder wasn't the problem, your neck was. Versus a functional approach where you complain about, not being able to walk correctly and you're just limping, and then your PT just gives you a cane to fix the limping, but doesn't help fix what's causing the limping to begin with. They're both appropriate and they both need to be done together, but you can't sacrifice one for the other. So we're not going to go into these, but these are the words, you'll have access to this later. These are the words for the structural manual therapy. When you're getting manual therapy and you're considering a therapist, they need to be well adapted and have a good sense of all of these techniques. You can't pick and choose. My amazing mentors told me a long time ago that getting into manual therapy was like going into a rabbit hole. And as soon as you open one door and you learn one technique, you're hooked, and you kind of have to stay on that course, because once you learn one thing, you have to learn everything. You can't pick and choose what you want to be involved with. You have to learn all of it. So you can't, a lot of clinics, when you look at their websites, if you look at it says what services we provide, and they say, oh, we do manual therapy, but if you ask them, some people will tell you that stretching your hamstrings is what they do. Well, if that's what they're considering manual therapy, you might want to look for another clinic or look a little bit deeper, because that's not enough for what you guys need. And then functional therapy, these are all the other techniques that we as physical therapists, we treat and use all of these. I use all of these with all of my patients, and I kind of put them in an order, for me, of importance for patients with connective tissue disorders. And you'll notice that stability and strengthening is actually pretty low on my list, because I treat patients from more of a functional strengthening standpoint. And if I have you do a joint stability exercise for one joint, and then you do it for all those different joints, but you never use them together, what's the point? If you can't take what I give you and then take it out of the clinic and use it once you get up to walk out, then I haven't done my job. So proprioceptive imbalance is a really important component that I feel like gets left out a lot for this patient population, and hopefully towards the end we'll have enough time. What time are we on?
Some time.
Okay. We'll be able to go through some of the photos that are kind of telling. But the main component of that allopathic versus osteopathic is that structure-function relationship, and that structure governs function, but function influences structure. So like I said, you can't do one or the other. You can't be just somebody that goes in and gets manual therapy and then does nothing with it. That's a waste of time for both the patient and the therapist. You can't go in and just do exercises with your person, because if you're doing things and you're not aligned properly, you're just re-ingraining bad patterns, which will continue to strengthen you in your dysfunction, and you won't continue to get better. So just like this picture, if you continue to hammer a nail that's bent, you're only going to make it worse. You need to straighten the nail out and then effectively hammer it into place using all of those techniques that we talked about. So we talked about connective tissue. Well, fascia, if you went back to the slides with all the words on it, myofascial release is one of the techniques that we use a lot. Fascia is that highly complex web of connective tissue that holds your entire body together. It's what I explain to patients. It's the fabric that holds your whole body together, and it's one single piece of connective tissue from your head to your toe. There's different layers of it, there's different regions of it, but it's all one piece of tissue, and it can't be separated. So that's why you can't treat one thing and not something else, because once you start treating somebody's ankle, you are going to affect their hip, you are going to affect their low back. So you need to be mindful of the fact that when you treat one area, you're going to affect the others. Then there's 3 categories of it, but different lecture, we'll just skip that. So why it works. So why all of this works together. The little red thing is not matching mine. So the red thing is your muscle or your injury area. Your muscle sends information into the spinal cord. It's moving all by itself. All right, so information goes in the top and it comes back out as motor information to the bottom. So if there's an injury and your body says, that really hurts, that's that little extra thing. Normally I can control that myself. And it says, that really hurts, so it sends the message into your brain and your spinal cord, and it says, well, okay, well, you're injured, so maybe you should shorten and do something about it. So then you start to spasm and you cramp, because that's an injury. But then the spasm and the cramp hurts, and it pinches on that injury, and then your body says the same thing again. And that's when you get stuck in these cycles of pain and spasm. And until you do something to change it, it's not going to. It's just going to be a repetitive cycle. So that's where physical therapy comes in. But then, if you're not paying attention to it, like most of us don't, myself included, human beings are pretty stubborn, and you just ignore it, your body's going to say, well, if you're ignoring your shoulder pain, I'm going to start to send that information somewhere else that you might pay attention to. So instead of sending it to you as shoulder pain, I'm going to start to give you like a weird random heart rate, because maybe you'll pay attention to that and think you're having a heart attack and do something about it. The same thing can happen in reverse with our patients with dysautonomia. You can have visceral or organ problems that are presenting with things, and then they can be causing your back pain and things like that. So if you're just complaining of back pain and nobody's looking at other sources of that pain, you also can be missing the boat. Again, I'm not touching this.
Yeah.
Anyway, if I click it again, will that slide come up? That's not what I see. Oh, you're seeing that. Oh, okay.
Tell me what to do.
Hold on. I just need to catch up.
Okay.
All right, there we go. So the spine and the ribs are a big area of where we treat. We treat a lot of facet joint problems. Did you say 5 minutes? Oh, okay. So the facet joints are these the facet joints are the joints on the side there, and they can get locked in place, or they can get turned and twisted, and aligning the spine properly so that your mechanics work is a really important thing. So with patients with connective tissue or hypermobility issues, a lot of times your pain is actually coming from the area where you're moving too much. But the problem is not that problem. The problem is a different area of your spine that's not moving enough, that's causing one of the other areas of your spine to move too much, which is causing the symptom. But just stabilizing that segment, unless that is the actual problem, sometimes you need to go and move the area that's not moving enough to then stabilize the area that's moving too much and causing you the pain. So sometimes treating an area further away from your symptom is actually more important. Which is why your PT and your providers need to be looking at your whole body. Now you can move. Thank you. So one thing I want to talk about specifically is rib subluxations, because people forget that ribs move. I hate to break it to everybody, but ribs do move. I've had this discussion with plenty of patients and physicians. Ribs are joints. Ribs have joints into the spine, and they do move, and if they didn't, you wouldn't breathe. Breathing, I consider a pretty important function. So a rib subluxation, they're not going to move very much because it's a very small joint and it's a very small area, but because they're so tightly fitted, the smallest motion in the wrong direction is going to cause you a problem. It's going to cause pain, and it's going to cause potentially other problems. Yeah. So if you look at where the ribs are aligned, if you look at the picture on the left, that rib, that's the edge of a rib, and all of that white stuff, those are all ligaments. Those ligaments hold those ribs in place, but for patients with connective tissue issues, there's no ligaments they're not that strong everywhere in your body, so they're not that strong there. So there's a little bit of an excess movement from your standard. But if you look more importantly at where the yellow line that runs right in front of it, those are the what we call the sympathetic chain. Those are the part of the autonomic nervous system. They lie right in front of those ribs. And those are your fight or flight reflexes. So when you get those, what we call dysautonomia reactions of, your heart starts to race and something's wrong, and for this patient population, it's very important to identify, why is that happening? Is it happening because you're having dysautonomia, or do you have a rib that's slightly pushing on something that's triggering a reaction? And which one needs to be addressed? It could be both. So when the rib goes out of alignment and it pushes on something and pinches and causes a spasm and then causes that nerve to be hit, you can get fluttering in your heart, and depending on where it is, or pain in your stomach and things like that. And then once that area of the spine is reduced and reduced into an alignment that's better and stabilized, and the ribs aren't pushing those nerves, those dysautonomia symptoms may reduce. If it's dysautonomia that's causing the problem, it can also start to cause spasms in that area, like we talked about with the spine to the muscle to the heart, and those visceral problems can then cause you back pain. So you might be complaining of back pain, but the back pain is coming from somewhere else. So that's why it's really important to have a good relationship with all your providers, because sometimes it might not be my problem. Even though you have back pain, it might not be my problem to deal with. So we already talked about dysautonomia. I can go on to the next one. So it's really important that you have a team approach. So patients with EDS, connective tissues, and all these comorbidities are really complex. So your physical therapist should be dealing with your PT issues. Nothing else. So they deal with PT issues because that's our job. We have to deal with, everybody that you have has to deal with things within their scope of practice. So I don't treat Chiari. I have patients that have Chiari. I treat all of their PT issues related to it. But sometimes I have to call Dr. Klinga and say, this isn't getting any better, and these are the symptoms that they're having, and I can't reduce those symptoms with what we're doing. I think you need to see them again. Everything is related, and so every member of your team needs to be involved. And you have to play a key role in being very specific when you're talking to them about those different areas. and using the right words when you do so that we can all communicate more effectively. But one thing that's a huge pet peeve of mine that was taught to me by all my mentors is you are a key member of the team, but you're not broken. And it is not my job to fix you. I cannot fix you. I can help you improve the best abilities that you have, and I can help you be the best version of yourself, but you're not broken and I don't fix you. So don't come in and ask me, or don't come in and ask any of your providers to fix you. It's very burdensome to everybody, and it's not giving you the power to get better on your own. And that's something that's really important that's going to come up over the next 2 days of the conference, is you have the ability to empower yourself to help yourself move through this line. So one key piece of information that I want all of you to take away is the difference between a subluxation versus a dislocation. From a very specific textbook term, a subluxation is when a joint comes partially out of alignment, so less than 100%. It's slightly off. The joint is still structurally aligned, it's just not the best it could be. It's part of the way out of the alignment. Or when it completely dislocates and then will reduce all by itself without anybody helping you. So that's called a subluxation. A dislocation is the complete full disruption of the joint surface where the two bones come apart and they don't go back together. So these are more severe and more dangerous. Unfortunately, the majority of the time people are using the wrong terms, and then using the wrong terms when you're talking to other providers, they can lead to very precarious conversations where if you were to tell you go to the doctor and you say, my physical therapist put my dislocated hip back in place, they're probably going to get a phone call from the Board of Health saying, what did you do? That's not your job. Well, the patient walked into my clinic, therefore I don't think their hip was dislocated, and that's not what I did. So being very cautious, you can't tell all of your providers, my ribs are dislocated. No, probably not. You probably have subluxations within 1 or 2 ribs, but being very cautious on what you say, because certain providers aren't going to be as understanding and you're just going to piss them off, and then they're not going to listen to the rest of your story. You're not doing it maliciously, but if you're not using the right terms when you're going forward, you just need to be more careful, because you could be sabotaging yourself for everything else, because then they're not going to listen to your story and take you seriously. Okay, so how to choose a PT. So when you choose a PT, you're basically going on a journey together. One more. Okay. Unfortunately, it's not a fun journey all the time. The road is not straight. There's a lot of uphill battles. There's a lot of ups and downs. You're going to get lost and you're going to be confused because nothing is linear in this kind of path that you're taking together. And sometimes you're kind of puzzle piecing things together as a team, and you're trying to figure it out together. So when you're choosing a PT, I have some general guidelines that we're going to go over, but basically you want somebody who's going to go on that journey with you and commit to that. I have patients all the time call me up and say, I want a PT who knows everything about EDS. Too bad. There isn't anybody out there like that, myself included, and there is no PT that specializes in EDS. You should have a PT that specializes in patient care. So you don't need a PT that specializes in EDS. Your PT needs to have some general guideline knowledge of what to do with these patients from a precautionary standpoint, but you really want to find that person that's going to be the best fit for you. They need to give you a lot of individualized attention. It shouldn't be kind of a factory clinic where they see 5 patients an hour. If that is the place that you're at, you want to find somewhere else. There's a place for that kind of therapy, but it's not for this patient population. They need to have, like I said, a wide breadth of manual knowledge, and if stretching of hamstrings is what they consider manual therapy, you need to ask them, do you know these other techniques? And if they don't, it might not be the right fit for you. You need to have somebody that's going to treat you as a whole person and not just a single structure. But in general, what I tell people, because I'll have people have their PTs call me, I just need help in what to do and how to go from there. I tell them you want to go low and slow. So I tell a lot of PTs when I see them, I don't care if your patient is 20 years old and they have all these comorbidities, treat them like they're an 85-year-old little lady with osteoporosis and about to have a heart attack. That's what you want to go with. And so low and slow is the game, and it unfortunately is if you push them too fast, you're going to have setbacks, and that's why people hate PT, is because people don't do that, and then we get a bad reputation. But you basically want to find somebody that's willing to go on the journey with you, and then to kind of treat you as a person specific to your situation, because everybody in this room may have the same diagnosis, but none of you present the same way. So even though I treat a lot of patients with EDS and Chiari and connective tissue issues, I don't treat any of you the same way. Every single person I has a different caseload. I'll flip the next one. So more importantly, so patients have asked me, when do you lose your PT? A lot of people stay with a PT or a doctor out of loyalty, but don't. If your needs aren't being met, it's okay to say, this isn't the best relationship for me to be in right now. I think, maybe I need to find help with somebody else. It's not that your PT is doing anything wrong. It just might not be the right person for you. But also that PT should recognize that maybe they're the problem and they're not helping you enough, because if your PT or your doctor has ever told you that you've plateaued and that you're just not getting better, you as the patient are not plateauing. Your provider has reached their limit of what they can provide for you. I constantly refer to other people and say, I need you to look at this. I can't get anywhere. So my patient's doing what I'm asking them to do, but they're not getting better. It's not because they're the problem. I must be the problem and I'm missing something. So I refer out to somebody who knows more than I do. So if that's not happening for you and you're doing the same thing all the time and not getting better, you need to move on. If you're currently being injured and you're unsafe in your clinic, PT is not supposed to cause you pain. PT is not supposed to cause you an injury. So if that's happening, you should also lose that PT. And if it's just not the right person for you, you really shouldn't have to struggle. You're going to be stuck with this PT, this person, for quite a long time on your journey. So if you don't like each other, you might want to find somebody else. Even if, like I said, they're not the expert, if they're going to work with you better and you're going to have a better relationship with them, that's who you want to be with. And so these are just some pictures that I wanted to show you. I wanted to kind of just, you don't have to answer, but look at this first slide and say, which direction are these pictures going? So from a progression standpoint, which one of these pictures is harder and which one is the patient in a healthier situation versus a weaker situation? So I see a lot of fingers saying that they're weaker here and they're getting better going that way. They're actually the opposite. So the patient was actually much sicker, medically, systemically weaker, doing higher level activities. And then this current picture over here was after she finally reached a new medical advancement for her, but she had significant functional setbacks and she had to relearn how to walk again. So she came back braced from head to toe after she had been able to stand on a BOSU ball and do all these high level activities. Then we had to regress her. So she may have been getting better on one side. Her medical and structural things are getting better, but her function plummeted. So that's why these patients are never going to go on the right timeline. And then go to the next one. So these were some of her when she was sicker and she wasn't able to do as much. She was able to look like she was doing a lot, but we had to modify everything she was doing. So this patient has given me permission. So in these pictures, she's fused from her head all the way down to her sacrum. So she is one of my most highly complex medical patients, but she's able to do all of these activities when she's medically stable, and she's progressed up and down throughout the years. So sometimes, like we said with the house, looking at somebody from the outside doesn't give you a picture of what's going on with them. And one more. And so we're going to save questions for the panel discussion, but that's about it for now. Thank you guys for everything, and we'll have the panel discussion questions afterwards, so don't ask me anything now. But